Good evening, everyone. I am Katyayani, and on behalf of Voice of Healthcare, it is my privilege to welcome you all to the National Aplastic Anemia Forum 2026, an initiative by Voice of Healthcare, supported by BSV Mankind. This year's topic, Burden of Aplastic Anemia in India, reflects the growing need to address the clinical, diagnostic, and treatment related challenges associated with this rare yet life threatening hematological disorder. Aplastic anemia continues to pose significant challenges in India, from delayed diagnosis, limited access to specialized care, to the complexities of long term disease management and bone marrow transplantation. Despite advances in hematology and transplant medicine, disparities in awareness, affordability, donor availability, and timely intervention continue to impact patient outcomes across the country. Today, the focus extends beyond disease management alone. It is about improving early recognition, strengthening access to advanced therapies, enabling multidisciplinary collaboration, and ultimately ensuring equitable and patient centric care for individuals living with aplastic anemia. Over the next 60 minutes, we will explore the burden of aplastic anemia in India, discuss current treatment paradigms, transplant strategies, real world challenges, and evolving approaches that can help improve outcomes and quality of life of patients. It is now my privilege to introduce our moderator and session lead for today's session, Dr. 𝗔𝗃𝗃 consultant hematologist and bone marrow transplant physician, Department of Hematology, Powai Medical Center and Hospital, who will be guiding today's discussion with his extensive clinical expertise and experience in hematology and bone marrow transplantation. Welcome to the session, sir.
Thank you, ma'am.
Joining him are our esteemed panelists, Dr. Rohan Haldar, consultant Hemato-Oncology and BMT, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Welcome, Dr. Rohan. Dr. 𝗕𝗂𝗿𝗀, Director and Head of Department, Hematology and BMT, Marengo Asia Hospital, Gurugram. Welcome, sir.
Thank you.
Dr. Abhishek Ranjan, Consultant Clinical Hematologist, Center for Blood Disorders, Ranchi. Thank you for joining us, Dr. Abhishek.
Good evening.
And Dr. 𝗠𝗲𝗃 𝗀, Clinical Hematologist and BMT Physician, Mumbai Onco Care Center, Dr. 𝗓𝗏 Hiranandani Hospital, Powai and Jaslok Hospital, Mumbai. Dr. Suraj will be joining us shortly. And with this, I would like to hand over the session to our moderator and session lead, Dr. 𝗔𝗃𝗃. Over to you, sir.
Sure. Thank you, ma'am. Okay. Can you just let me know whether my slides are visible?
Yes, we can see.
Sure. Okay. Thank you very much. First of all, thank you for this opportunity, and I welcome all the panelists to this session. What I thought I will do is thank you all the panelists for being a part of this discussion. With a very small introduction, aplastic anemia, we are all aware that it is peripheral pancytopenia with a hypocellular marrow, and it is classified into severe, very severe, and moderate or non-severe aplastic anemia based on the cellularity of the marrow and the neutrophil count and reticulocyte count. And the treatment is again dependent on the severity of aplastic anemia, with matched sibling donor or hematopoietic stem cell transplant being reserved for patients with severe aplastic anemia, young age, followed by triple therapy with 𝗔𝗃𝗃𝗁 or 𝗔𝗯𝗵𝗃. That's the next treatment, or at least 𝗃G with cyclosporin or cyclosporin alone with androgens being the last. Okay, so I'll start the session which is predominantly, the burden of aplastic anemia in India from the epidemiology and disease burden. I'd actually put these in. The first question is for Dr. Rohan Haldar. Is the epidemiology of aplastic anemia in India different from that observed in Western countries in terms of incidence, prevalence, and reporting patterns?
Thank you for the question. As far as I can remember, with regards to the epidemiology, I mean, the incidence is higher. I mean, as far as I can remember, when compared to the West, we see the numbers are higher. As far as I can stretch my memory, if I'm not wrong, there was a study from AIMS where they had over a period of about 4 or 5 years, about 1,500 patients, uh, from around 20 different states from India. Over a period of This was a study conducted where they saw retrospectively patients over a period of 7 years, and there were 1,500 patients from 20 different states. What was most striking was because AIMS, draining mainly from the northern part of India, we saw most of the aplastic anemia patients were coming from northern districts of Bihar, Jharkhand, and also from West Bengal. Most and about 57% of them were like non-severe aplastic anemia, with about 33%, I think, being severe aplastic anemia. The rest were all very severe aplastic anemia. Um, yeah, and there is some regional differences, I believe, also, but I cannot really vouch for what happens to to the southern counterpart of our country.
Okay. Thanks, Dr. Rohan. I concur with your views because there are very limited registries, aplastic anemia registries in our country, and we cannot be absolutely sure about the epidemiology of the disease. But as far as the rough guidelines based on AIMS data and Christian Medical College Vellore data, it is roughly around 5 to 8.8 per million per year in the Indian context, whereas in the Western trends it's around 2 to 3. And the median age again is definitely much lesser in the Indian cohort compared to the Western cohort. But again, and gender skew also is more towards males, 2.3 is to 1%. But that again could be because of preferential males coming for care rather than the females. It could well be very skewed, or it is probably right, and because of unfair representation of the ladies, because the ladies may be lesser in number. Second, as Dr. Rohan alluded to, the presentation severity in our country, most of them present either as severe or very severe aplastic anemia compared to a lower severity of aplastic anemia in the Western population. The next question is, what are the key reasons for the higher incidence of aplastic anemia observed in Asian populations? Dr. Meath?
Hello, Dr. Rajshekhar. First of all, warm greetings to you. Long time not seen you, not met you, heard you. Really great to interact with you over this platform. So thank you so much for sort of making me a part of it. So I'll just take a slight detour, maybe 10-second detour. I wish to sort of congratulate and wish all of us who are present here, maybe viewing us or joining us on this platform, to wish all of us on behalf of World Thalassemia Day. Today is supposedly World Thalassemia Day also. So we have to make that awareness in addition to aplastic anemia. Since today is World Thalassemia Day also, we should also convey the message that today is Thalassemia Day, and thalassemia is equally important disease that we should be conveying to our audiences. Having said that, the topic or the question that we are discussing about aplastic anemia, I perfectly concur with what Dr. Rohan just mentioned about the prevalence that Asian countries are definitely showing a higher incidence of aplastic anemia as compared to the West. The interesting question, why so? Why the incidence of aplastic anemia in these countries is high? That is something that there have been multiple studies that have been done, and the answers have tried to be found out in multiple scientific data and scientific studies. Fortunately or unfortunately, we have some limited answers for that, and that essentially comes down and boils down to the exposure of increased chemicals, whether it is in the form of ingestible chemicals, whether it is in the form of air chemicals, or it is in the form of food that we eat that is contaminated with the chemical contents, that ultimately leads to the increased incidence of chemical exposure, ultimately relying and resulting in sort of some higher incidence of aplastic anemia. The other non-idiopathic or a causative agent related aplastic anemia, that is bone marrow failure syndromes, have been shown to be associated with certain medicines, but that is difficult to comment that the ingestion of those drugs is higher in the Asian populations than the Western populations. But yes, the exposure to chemicals is one agent, and exposure to certain viral agents that supposedly is contributing to higher prevalence and higher incidence of this, not a cancerous but not less than that disease that we are discussing about aplastic anemia.
Thank you. Thank you, Dr. Meeth. Okay, as Dr. Meeth said, there is a shared vulnerability, that is the genetic vulnerability, which is common to Western population as well as the Indian population. But what differentiates, in fact, in the Western population, the gsTM polymorphism is much higher, in fact, okay, making them more susceptible for aplastic anemia. But the problem is they have a decreased environmental load, that is exposure to benzenes and pesticides, like Dr. Meeth said. So that is the key multiplier as far as I can see. So you have a shared vulnerability, but with a high environmental load, that is benzenes and pesticides and other environmental agents, which leads to increased incidence of aplastic anemia in the Asian and Indian continent. Okay. This was actually supposed to go to Dr. Suraj, but till he joins, I think somebody else can answer this question. Age distribution of aplastic anemia in India, and what implications does this have for early diagnosis and long-term outcomes? Dr. Rohan, if you can be kind enough to take this question. Age
distribution is generally like bimodal. Okay, so we see a big chunk of our patients are adolescent and young adults in the age group of 15 to 25 years. These are the major chunk of patients, but there's a small chunk of patients who are elderly, so beyond 60 years. When you compare to the Western data, in the West, the median age would be it would be 15 to 25 in Indian and other young Asian countries. It is probably again in the teenagers that we see more often. Elderly also is there, but again, I would say the range is wide. It is somewhere between 15 to 36 that we see in India, and again we will see an elderly group as well. And with regards to the second part, you had one other part, or this was the only one.
What implications does this have for early diagnosis and long-term outcomes?
Yeah, so basically there are two things. What if I may put it, one thing is with regards to early diagnosis, if you pick up aplastic anemia early, starting therapy early makes a difference. If you can start the therapy earlier, if you have because there's an immune mediated attack that's going on in the marrow, if you can pick up earlier, before these patients develop very severe or severe aplastic anemia, if you can start with some form of immunosuppressive therapy, maybe cyclosporine or whatever, you can probably salvage some of the residual stem cells, and the likelihood of response to immunosuppressive therapy is much higher. So obviously, a lot of the aplastic anemia patients are undiagnosed, and they come almost 3 to 4 months late from the time actually the diagnosis can be established. So this is one big problem that I see, and I think this is a big problem which I see in India, that there's a lot of delayed referrals that take place, and because of which the patient loses a lot of precious time.
Sure. Okay. Like Sir said, there is in the Western population, that is seen here as the gray curve, there is a primary peak and there is a major secondary peak. Whereas in India, it is predominantly a single dominant peak, which is a youngish patients. The hypothesis is that the lower rural life expectancy and reduced access to high-end hematological diagnosis for the elderly in peak in India may obscure the second peak. Okay, but definitely in India, the population of aplastic anemias is in the younger population. Okay, the next question is to Dr. Abhishek Ranjan. To what extent do disparities between urban and rural healthcare settings influence the diagnosis, reporting, and management of aplastic anemia? And can you suggest some strategies which can help bridge these gaps? Dr. Abhishek, I think you will probably have to unmute, meaning your camera is not visible. We're not able to see you, sir.
Sir, my camera is on. I'm not sure whether it is functioning or not.
Okay.
But
okay.
can you hear
yeah,
me, sir?
We can hear you. We can hear you.
Yeah. The thing is, sir, most of our patients, they belong to the rural areas also. And India, where most of the patients are in the rural areas. So these patients, in lack of pathologist and diagnostic services, these patients, they don't have access, especially to the complete CBC routine investigations, bone marrow aspirations, biopsies, newer modalities like NGS and all. So these patients who belong to the rural areas, they usually are referred very late to the cities, to the higher tertiary centers where we hematologists are practicing. So as compared what we are seeing in the metros or in the tertiary cities, there is early referral. Wherever there is 𝗫𝗫𝗀𝗃𝗃𝗃 or 𝗫𝗫𝗃𝗃𝗃, these patients are referred quite early to the hematologist. Otherwise, in semi-urban areas or in rural areas, they simply get blood transfusions or they simply get platelet transfusions. And by the time we get these patients, they usually have sepsis. And that is a very big challenging in lack of awareness. So this is the biggest challenge what we are facing, especially in areas like Jharkhand, where we have no pathologist even in the peripheral part of the state. So what coming to the next question, what we can do? So the most important thing is the awareness, mass awareness to the clinicians as well as to the patients, early referral. So as we know, we are now having mobile medical vans also, which are going in different peripheral areas of the districts. So we must educate our medical officers where we can have timely and early referral to the tertiary centers.
Sure. As rightly pointed out, there is delayed treatment, prolonged anemia, leading to extreme, supportive treatment alone, which leads to high mortality. This is a case more in the rural population where they lack diagnostic tools, and it's primarily detected only when it becomes very severe. So, of course, there is diagnostic delay leading to disease progression. There's a referral bottleneck. There is clinical deterioration and an outcome collapse.
Can I just interrupt for a second, Dr. Rajshekar?
Yes, Doctor.
Just want to add on one point. Dr. Abhishek is the king in Jharkhand. I am very much, he's a dear friend. There is no question for that. But what point I wanted to add here is, there is some discrepancy. One is, of course, as Dr. Abhishek was saying, that is about the referral system being slow in the tier 2, tier 3 cities as compared to tier 1 cities. The other problem is also with the patients. As in, the understanding and awareness level of the patients in tier 2, tier 3 is much lesser as compared to tier 1 cities. Even if the referring doctors or the doctors tell them, like in tier 2, tier 3 vis-a-vis tier 1, they would be much more reluctant to travel to maybe higher centers for getting them diagnosed, treatment. That is another thing. And that again, the answer to that the solution to that again lies in creating more and more awareness, not only amongst the doctor community or the medical community, but also amongst the general population. That is the thing that I wanted to highlight here.
So again, a lack of local diagnostic capability, like Dr. Abhishek said, portable point-of-care diagnostics and personal training, absence of hematologist, telemedicine, and digital health, weak referral pathways, dedicated rapid hub and spoke networks, and financial constraints and complaints, targeted subsidies and logistic supports to these patients may help. Okay, the next is going on to etiology. Welcome, Dr. Suraj. We missed you. So welcome, sir. Etiology and risk factors.
Thank you.
What proportion of aplastic anemia cases in India are classified as idiopathic compared to those with identifiable secondary causes? And how does this distinction influence clinical evaluation and treatment planning? Dr. Rohan, please.
Yeah, so almost most of the cases are, acquired aplastic, idiopathic aplastic anemia cases that we have come across. There'll be about, if I may say, there'll be about 5 to 10% of cases who are, not who are not acquired, but rather inherited causes of, who are having inherited causes of marrow failure. Very rarely you could find, it's very difficult to establish an etiology in every case. Most of the cases we don't find any etiology, or even when we look into their past history, no matter what. Once in a while, again, I cannot put a number to it, but once in a while you will get post-hepatic aplastic anemia that we see, after a period, after some, hepatic insult, that the patient develops aplastic anemia. It is a very, I think, relatively, it's being recognized more often now. And with regards to its influence on evaluation and treatment planning, well, see, if we are, it is always important to rule out an inherited marrow failure syndrome while evaluating for an aplastic anemia, because the treatment differs, and also because the treatment will always be guided, and nowadays we are also using the latest technology like next generation sequencing. If there is, if there are any morphologic any telltale changes of any Fanconi anemia or any inherited marrow failure syndromes in the patient, we use NGS to diagnose and take help of such tests to just confirm the diagnosis and to come sort of rule out any inherited marrow failure syndrome, and then we are sort of done and dusted that this is acquired aplastic anemia.
Okay. Just to summarize, as 65 to 75% in India is idiopathic or acquired aplastic anemia. 25 to 35% is secondary causes. This is all based on the Christian Medical College Vellore and AIMS data. We don't have well-functioning registries, so it is very premature for me to extrapolate this to the whole Indian scenario. So roughly 65 to 75%, and of course, like Sir said, in idiopathics, the treatment is more transplant and immunosuppressive therapies, whereas in secondary or the inherited bone marrow failure, you would prioritize hematopoietic stem cell transplant with utilizing reduced intensity conditioning regimens. How significant is the role of environmental exposure such as pesticides, benzene, and industrial chemicals in the development of aplastic anemia, particularly in rural and occupational settings? Dr. Meeth, sorry for giving you hard questions.
I would say, sir, but I am not very clear on the percentage. If we are seeking a percentage, exact percentage, that what percentage of the patients who have been exposed to certain chemicals and they developing aplastic anemia, I'll disappoint you and not be able to answer that. But I can say yes, definitely these environmental exposures do play a role. Definitely play a role. There have been studies that have shown that people living down the sort of riverbed basin where a lot of chemicals get deposited, they have got higher prevalence and incidence of developing different types of cancers as well as aplastic anemia. Sometime back, there was a study that was published almost 2 years back that compared the incidence of aplastic anemia. I'm working in Delhi NCR, so two different cities of NCR were compared, and depending on the percentage of exposure to sort of different type of chemicals. So there is a industrial belt in something called as Bhiwadi belt, and there is a non-industrial belt. So there was a study that was published, Bhiwadi versus non-Bhiwadi NCR region, industrial versus non-industrial belt. There was almost 2.5 to 3 times more incidence of developing cancers and aplastic anemia in those regions where the chemical exposure was higher as compared to those regions where the relatively less percentage of chemical exposure was there. So I think this answers to a certain extent what you're trying to ask me. But again, what percentage of patients who are exposed to certain chemicals will develop aplastic anemia? I don't have a ready answer for that.
Sure. Thanks a lot. Okay, again, the relative risk in benzene exposed people is around 3.5, whereas pesticides, organophosphates, the relative risk is about 2.1, and DDT is 6.7, and carbamates is around 7.4. This is all from the internet. I am not an expert in this, so I thought some data to this one. Next is Dr. Suraj, sir. What is the clinical relevance of drug-induced aplastic anemia in India, especially in context to commonly used medications such as anti-epileptic drugs, antibiotics, NSAIDs, and traditional or alternative medications?
So, sir, this also sometimes when we see the idiopathic aplastic anemia, when we rule out the inherited syndrome, so usually we don't deep dive into such details. But there are interesting cases, like I have 2 to 3 patients aplastic anemia which are having the on the traditional sulfonylurease medicines. Long time they develop non-severe aplastic anemia, and anti-epileptic drug, most of the people, you see when we see most of the times referred patients, so the any patients which are on anti-seizures medicines and they refer to us, I have not seen, and chloramphenicol like medicines like that, it's absolutely nobody's using these days. So most of the patients what I've seen drug induced mostly are patients which are on sulfonylureas, traditional derivatives. That's all. And the interesting cases, what I've seen, people post-COVID, they try to have on many medications for lifestyle support, and the content of those medicines are not known. So usually there are some spurt of aplastic anemia post-COVID also because of these alternative medicines, but exact percentage I am not sure, sir.
Okay. Again, this is something which I picked up from the internet. Okay. So linezolid, cumulative toxicity, if you use it more than 14 days, driven by MDR TB infections, has a higher incidence of bone marrow suppression. Likewise, NSAIDs, diclofenac and indomethacin, 8 times and 12.7 times the risk. Carbamazepine, more than 50% mortality rate if there is aplastic anemia after its use. Methimazole and chloramphenicol, again, have been implicated in this. But more important in our setting is the rampant use of Ayurvedic medicines, bhasmas. Most often they contain a higher concentration of heavy metals, because of which a lot of problems, MDS, renal problems, as well as aplastic anemia has been implicated in these because of the increased mercury, arsenic, heavy metals and all. Okay. How does viral hepatitis contribute to the onset of aplastic anemia? What are the diagnostic and management challenges associated with such cases in routine practice? Dr. Abhishek?
In almost 5 to 10% of the cases, we can elicit a history of jaundice 3 to 4 months or 6 months prior to the onset of aplastic anemia. And usually these cases of viral hepatitis, they are non-A, non-B, non-C to non-E hepatitis, may be associated with the prior infection with EBV or CMV or something, some other viruses, which obviously we don't have, we are not sure about those viruses. So, but in almost 5 to 8% of the cases, especially in Asia, we have our patients give history of jaundice. So, regarding the challenges associated with such cases, if the jaundice has subsided, then definitely there is no risk in treating those cases, and these patients are treated as per the protocol. So this is my understanding.
Yeah.
So if the patient is having ongoing jaundice, then definitely we have to find out the cause. We have to try to get the ultrasound and all, and many drugs like 𝗕𝗏𝗵𝗊 and all, those drugs we have to avoid.
Okay. The prevalence in aplastic, sorry, is somebody else contributing? Okay. Prevalence in aplastic anemia in the Western population post hepatitis is around 2 to 5%, whereas in the Indian subcontinent is 4 to 10%. And the HEV genotype 3 is more common in the Western population, whereas genotype 1, which is 𝗕𝗂𝗏𝗏 is much more common. And the timeline and the shared mystery is similar in both Western population as well as the Indian subcontinent. Of course, as Dr. Abhishek said, there is initial episode of hepatitis. There is biochemical resolution of the jaundice, and about 4 to 6 months later, they present with severe pancytopenia. And this is likely because of bystander effect, where the cytotoxic T lymphocytes expand, and even after they clear the hepatitis E virus, they target the healthy hematopoietic stem cells. Okay, going on to biological and genetic considerations, what is the current understanding of immune system dysfunction in the development of aplastic anemia, and how does this influence therapeutic approach in clinical practice? Dr. Rohan, please.
So, sir, basically now what we understand is that there is an immune-mediated attack on the marrow and the marrow progenitor cells, and the immune-mediated attack is due to some kind of an autoimmune phenomena. So, because of which there is the marrow cells get depleted because of the immune system doesn't recognize them or whatever, and the marrow cells get depleted and there is progressive onset of pancytopenia. Since this is the basis of aplastic anemia, and obviously there's a trigger, there's something that triggered this autoimmune phenomena, which again could be environmental agents or radiation or whatever, or some other virus related, which is most often than not difficult to recognize, and and this forms the basis of the further treatment in the course. So hence the underlying treatment involves immunosuppressive therapy, that is ATG and cyclosporin, and now we have added TPO agonist to the mix.
Okay. So again, like Sir said, the first part is the aberrant recognition by CD8 or cytotoxic T lymphocytes, some antigen on the hematopoietic stem cells, and oligoclonal expansion of cytotoxic lymphocytes by severe upregulation of linker for activation of T cells, and then the perforin and granzyme delivery and destruction of the hematopoietic stem cells. So obviously there is a polarization towards type 1, which is a pro-inflammatory phenotype of the T cells, and there is a decrease in regulatory T lymphocytes, because of which there leads to destruction of the hematopoietic stem cells. In what ways do nutritional deficiencies contribute to bone marrow suppression and disease severity in Indian patients? And how can these factors be effectively identified and managed? Dr. Meeth?
So, sir, if I am able to understand, are we saying that nutritional deficiencies that contribute to the development of aplastic anemia,
Okay, I should
or
have
in
probably
general we are saying?
I should have worded it different. How do these nutritional deficiencies affect our diagnosis of aplastic anemia? Does it influence
Okay,
the
okay,
diagnosis of
okay.
aplastic anemia? I should have worded it that way. I'm so sorry.
Yeah, yeah. No, no, so perfectly fine, sir. So, like, I think, yeah, the most common, I think, like, this raises a very important and actually a pertinent question, that why aplastic anemia is diagnosed at a later stage in India. The most common reason we have to understand, the most common factor basis which aplastic anemia is diagnosed is the pancytopenia. And pancytopenia essentially means there is a hemoglobin low, WBC low, platelets low, all the three parameters in a CBC parameters are low. But there can be 100 different causes of a low sort of pan, or like there can be 100 different causes for a pancytopenia. Aplastic anemia is one of them. And fortunately or unfortunately, the most common cause in India for a pancytopenia is a nutritional deficiency. Most commonly we see is B12 deficiency. Many a time we have seen that, like, we know that India, like, majority of the people, if not all, but majority of the people are vegans. Vegans is they are much more prone to develop a vitamin B12 deficiency that can manifest present as a pancytopenia or variable cytopenias. So B12, vitamin B12 deficiency is the most common, we can say, sort of a most common sort of differential for any person who is presenting with pancytopenia. Not only this, combined nutritional deficiency sometimes, like if there is extreme malnutrition in terms of combined protein deficiency, carbohydrate deficiency, fat deficiency, that has been shown, and we know that there is enough literature to suggest those people also at some point or the other develop pancytopenias. Infections, we have discussed like significantly about multiple viral infections, whether it is HIV, whether it is EBV, whether it is CMV. We all know that these type of common infectious agents, even influenza for that matter, at many times, like we see a seasonal sort of flu that is rising, and people come to us with sort of pancytopenia. We know that infectious mononucleus EBV is one of the most common causes. But yes, having said that, not only EBV but other viruses also are known to contribute to this. So ultimately, what happens is, when a physician who is sitting at a tertiary care center sees a pancytopenia, maybe he, like, the patient is having fever or something, he may either write to take certain medications that affect or try to control the viral infection. But if there is an underlying aplastic anemia ongoing with that patient, the diagnosis will but obviously get delayed, because the doctor would call the patient after 2 weeks to repeat a CBC. If he's good enough and educated, then he'll call after 2 weeks, and the patient will be smart enough, he will come after 4 or 6 weeks, and by that time the pancytopenia would have worsened, or maybe it would have been static, the patient would have developed fever because of immune compromised status, and ultimately may end up in ICU, as Dr. Abhishek was saying that I have seen his OPD, like it is beaming with aplastic anemia patients. So what I mean to say, this is the reason that is contributing to the development of a delay in diagnosis in our Indian context, especially more in the rural setting.
Sure. Thank you. Exactly. You know, these are great mimickers of aplastic anemia. Most of the times, these are the reasons for a delayed referral and a delayed diagnosis in aplastic anemia. Like, what evidence supports the role of genetic predisposition in aplastic anemia among Indian populations, and how should this influence diagnostic evaluation and patient counseling? Dr. Suraj sir?
Yes. So, whenever we see, because the most common age group where aplastic anemia is diagnosed is children and young adults in Indian scenario. So we always are in a twist, like whether it is inherited or it is acquired immune regulated problems, and because it has their own diagnostic as well as treatment modification depend on the inherited. And we see Fanconi, DKC, Diamond-Blackfan syndrome. These are the inherited bone marrow failure syndromes. But most of them we see in the OPD with some characteristics, short stature, skeleton, lip abnormalities, and pigmentation. But sometimes this can be misleading. So usually we do testing like Brekke studies, telomerase testing, and now germline NGS panels to know. So the implication and influence is too much, because starting from the donor selection, conditioning regimen, long-term outcome. These are important because cyclophosphamide dose has to be reduced in the conditioning. Donor should not have this mutation present while we select as a donor. And the most important, if everything goes well, what is the long-term output? Because many of these people can suffer from pulmonary and liver-related and secondary malignancies also in future. So the prognostication to the family should be very clear. So there is a big difference in managing the inherited bone marrow failure syndrome versus our immune regulated, with different outcomes depending on the conditions.
Sure. Okay. Again, studies from India have demonstrated that more than 50% of aplastic anemias have significantly shorter telomeres compared to controls. Very surprising. Second is HLA class 1 and class 2 associations. The first HLA allele association in India identified that HLA-DR-B1, that's 1502 allele, has a positive association with acquired aplastic anemia. And there are, in fact, germline variants in acquired aplastic anemia in around 5 to 30% of adult patients with acquired aplastic anemia in Asia, including India, which includes, 𝗵𝗃𝗃𝗃, TERT, and SAMD9 or SAM9 ligand. This one. Again, the increased incidence of consanguinity gives rise to more familial cases of inherited bone marrow failure syndromes. Second, so how does it influence? We'll have to mandatory chromosomal testing even if they don't have any phenotypic abnormalities. Again, next generation sequencing panel, including TERT, TERT, and DKC to rule out inherited bone marrow failure syndromes. 𝗵𝗃, telomere length assessment, and PNH cloning are coming more and more into the diagnosis of aplastic anemia, even for adult patients, because sometimes you don't have any phenotypic abnormality in an otherwise who looks like an idiopathic or acquired aplastic anemia patient. Again, next is to Dr. Abhishek Ranjan. How important is the identification of inherited bone marrow failure syndrome in patients presenting with aplastic anemia? And what challenges exist in implementing? I think some of these questions have already been answered, but you can just summarize, Dr. Abhishek.
So it is very important to diagnose inherited bone marrow failure syndromes, especially in patients who are less than 40 years old. So because the entire treatment of immunosuppressive therapy and depends on whether it is inherited bone marrow failure or it is acquired aplastic anemia. Cyclosporin obviously doesn't work in inherited bone marrow failure syndromes, and we have to go for bone marrow transplantation in case of 𝗵𝗃𝗃𝗃. So we have different types of conditioning regimens in case of 𝗵𝗃𝗃𝗃, reduced dose conditioning regimens. So even in case of inherited bone marrow failure syndromes like 𝗵𝗃𝗃𝗃, the patient may not have phenotypic presentations. So we have to go for the stress karyotype. As well as we have to go for the NGS in order to identify these patients, apart from the physical examination of the patient.
I think Dr. Suraj also alluded to all these points, about the monitoring of the patients especially for long-term malignancies, side effects of the conditioning regimen. All those counseling needs to be done. I think we are going into more difficult healthcare system and public health challenges in Indian aplastic anemia. What are the major barriers to early and accurate diagnosis of aplastic anemia in India, including limitations in awareness, diagnostic infrastructure, and referral pathways? Dr. Rohan, please.
Yeah. So basically, there's lack of awareness. Not only among general public, but also among a lot of general physicians regarding aplastic anemia. It's a very difficult disease to pick up when sometimes when the patient presents at very early stages. The patient are many times misdiagnosed with like say nutritional deficiencies or maybe immune thrombocytopenias. So obviously, because all of this add to the delayed referrals. Also, though things are improving, we have we have improved our diagnostic capabilities. We are able to do marrows, and also we are able to do stress cytoidics. Also, we have moved the bar ahead. We are able to do NGS wherever we feel the need. So the infrastructure, the diagnostic infrastructure is not bad, but definitely improving. There's still a lot of work to be done, and I think it's a work in progress. Yeah, referral system is something where I think India, being such a large country, is still an issue, and I think there have to be robust, referral systems to track the patients, so that if at all, if there is something that is picked up on this routine CBC, is flagged, and the physicians have to really be more tuned to the fact that okay, there's something wrong, maybe I need to get a hematology referral at the earliest. It may not be significant, but there's nothing wrong in getting the hematologist on board as early as possible. Maybe there's nothing, maybe it was just something, most likely a post viral thrombocytopenia or whatever, but early referral makes a difference. So I think these are some of the things that I think, and we need more awareness among physicians to to think that it's a really serious disease that needs early intervention.
Okay, so obviously there are many problems. Okay, so initial presentation and primary care to begin with, delayed referral, limited specialist access, inaccurate triage, financial barriers, systemic confusion, redundant testing, lost for follow-up, misdiagnosis, advanced disease progression, treatment delay, preventable mortality, and geographical disparities are some of which that can be alluded to. Now, again, as Dr. Rohan already said, awareness recognition is probably the first thing. Second is diagnostic infrastructure. Third is referral pathways. And failure at any of these single gate can result in treatment, abandonment, or mortality. Again, so what is the requirement? Even the rural and primary health centers should have automated analysis to begin with. Bone marrow biopsy facility should be there in primary health centers, and trained personnel, if possible, should be there, or at least a early referral system, like Dr. Rohan was saying, should be present. Advanced genomic tools, at least in the tertiary care centers where they are being referred to, should be available for the patients, even from the rural population, at a subsidized rate. Okay, so again, this is what we all go through. Okay, a person who gets referred also doesn't necessarily mean he will go to the tertiary care center. He goes to a local provider too, and sometimes an alternative practitioner, and because of which there is increased risk, infection risk, transfusion burden, and financial drain. And ultimately, when they come to the specialized center, they are either not fit for treatment, or they don't have the money for treatment. Okay, this is the reality of what we face in everyday practice. Okay, so again, primary cause, this is just to summarize this one. I'm not going to go into this details. The next question is, how does delayed diagnosis impact patient outcomes, particularly among younger population? What interventions can help reduce these delays? Dr. Meeth?
Sir, I think we have already touched upon these points, but I'll still reiterate the same. So, delayed diagnosis is delayed justice for the patients. There is no second thought about it. And very clearly, we have to understand that the diagnosis delay is a day lost, is a week lost, is a month lost, and that ultimately is going to cost us in terms of patient health. So, for whatever reason the delays are happening, irrespective of that, that definitely impacts clinical outcomes. The patient who is otherwise well today develops a fever tomorrow, lands up in ICU day after tomorrow, and maybe succumbs after 2 days. So that is what can be the magnitude of impact of delayed diagnosis. The only way is that definitely holds true for younger populations, because if they're diagnosed early, they can still be alive. As simple as that. If they are diagnosed in time, before the complications set in, before the infectious cascade sets in, before that, if they're diagnosed, they can be taken up, worked up in time. They can undergo whatever treatment they are capable of undergoing, whether it's a transplant, whether it is immunosuppressants, whatever the medicines, whatever the treatments the patients can undergo, they undergo the treatment. At least they are in line, they are in sync, that ultimately they can get cured. That is what the chances they have. How can we reduce those delays? The only way I understand is to increase. I think all of us have reiterated the same thing, starting from Dr. Rohan to Dr. Abhishek to Dr. Suraj, and in your presence, Dr. Rajshekar, is the only thing that can reduce these delays is awareness, awareness, and awareness. Not only to the doctor community, to the medical community. I want to still re-emphasize, VOH has the capacity to reach to the masses. We should educate the masses to the general population. If you are feeling weak, if you are feeling bleeding sites from anywhere, whether it is oral cavity, nose, skin, anywhere, if you are having recurrent fevers, please do not neglect it. Please do not stop thinking about it. Go to a proper specialist, get a CBC done, go to a proper hematologist. I must say that the pathway of proper referrals can sometimes need to be bypassed, and a direct approach to a hematologist is what is required whenever a CBC is showing these type of red signs of low hemoglobin, low WBC, low platelets. Please go to a hematologist nearest available to you directly, so that you can be diagnosed in time, counseled in time, the treatment can be initiated in time, and that is something that can save a life. That is what I have to say here.
Sure. Thanks, Dr. Meet, for summarizing. Okay, of course, with passage of time, there is increase in mortality rate, which is what this graph actually shows. And, while the Western population has an 80% survival rate, in this one, there is a 7% treatment mortality, and there is a transfusion trap, and only around 30% of patients actually reach some kind of treatment at least. Forget about the optimal treatment, some kind of treatment, at least only 1/3 of patients actually get do some kind of treatment. Okay, again, this delay can lead to evolution to myelodysplastic syndrome, or in some cases, leukemia also. Okay, so how do you do it? Again, like Sir said, Meet said, awareness, 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 rapid
Thank you
pathways
so
of
much for calling me Meet and not Sir. Thank you so much.
diagnostic toolkits should be available in the point of care, and specialized training also should be given to the first tier of population. Okay, what are the current gaps in national level data, disease registries, and epidemiological tracking for aplastic anemia? And how do these gaps affect healthcare planning and policy decisions? A very, very difficult question for Dr.
Yeah.
Suraj.
Actually, the problem in Indian practice is we try to treat when the patient's been diagnosed, and there are no proper registries available in Indian setup. So, as everybody knows, in India we feel the aplastic anemia percentage is much higher than the worldwide because of the various issues. But currently we don't have a proper registry where we can register the patients. So I practice basically in a Borivali area where the population is 12 lakhs. So as per that population, we should see 2 to 3 patients per year. But I personally see 6 to 7 patients per year in Borivali belt. Forget about the rest of belt. So there is a huge gap because there are no registry available. So we don't know the exact numbers here. So the tracking epidemiology, it's always a challenge because we don't have registry. We don't document the epidemiology of disease, or sometimes we just try to see whether it is inherited or acquired and try to treat. So that because of that, also the epidemiological tracking is vastly ignored in our practice. And if we want to do the policy making and tell government to take, first is we should think for proper registry where we document the cases. like we do for other BMT and leukemia patients, like we have now the national-wide registry, so that we can influence the decision. Because as the previous slide telling, like 8 as a and have only 30 to 32%. So that is the very eye-opening, because with the standard treatment, 80% of the aplastic anemia can get cured.
Okay. What policy level interventions and healthcare system reforms are required to improve disease awareness, reporting, and equitable access to treatment across India? Dr. Abhishek?
Sir, as we have already discussed in the previous sessions, so first of all, we need to go for the mass awareness through newspaper, print media, whatever, for the mass to educate the importance of pancytopenia, and this patient should be referred early. And as we don't have the registry, so, and we are simply treating the patients, though we are getting the cases, but we are not getting it registered on the national portal. So we have to make a national portal available, and based on that prevalence or prevalence of the disease, we must educate our policymakers to incorporate these treatment in our healthcare systems, like availability of horse ETG and all in government system, like 𝗕𝗵𝗶𝗿𝗀 schemes or Mukhyamantri critical care schemes, and availability of bone marrow transplantations. We don't have the transplant facilities available. Poor patients, they cannot go for the transplants, from where they will get the fund of around 15 to 20 lakhs. So we must educate the government the need to fund horse ETG and for the transplants, like we have educated our government for the hemophilia patients.
Okay. Okay. As everybody said, you cannot allocate resources to a crisis which you cannot measure. Okay. So our lack of registry is probably one of the most important reasons for this huge gap. Okay. So the root cause is inaccurate incidence data. Okay. The policy failure is government fails to fund specialized treatment centers or high-cost therapies like ATG and hematopoietic stem cell transplant. There is a clinical delay, absence of early referral, and because of which it has led to a lot of problems. Okay, now I want to, in Tamil Nadu, they have actually started this STAR program, which is an aplastic anemia registry, okay, where there is a nodal center in Chennai, and they actually contact all the hospitals to document their aplastic anemia cases. This is only two years old, but they have started it, and it's actually worked quite well. So even my center, we will have to report all the aplastic anemia cases which we treat or diagnose into this registry. So this is a registry for Tamil Nadu. A similar program can be done for all the states, and probably a center, this one, which collaborates with all the states, can give rise to a Indian registry, is what I feel. So again,
Sir, whose initiative is this? This is government initiative or some private body initiative?
No. This is government initiated through Apollo Cancer Center. They have used, not Apollo, the Adyar Cancer Center. They have used Adyar Cancer Center as the nodal place where they collect all the data from the hospitals in Tamil Nadu, and they collate the data there. So what is the diagnosis?
So those places where there is a hematologist sitting, only those centers will be empaneled, something like that.
No. Not only the hematologists, even oncologists have been taken into this one, because there are many hospitals where oncologists also treat aplastic anemia. They've taken into consideration that, and they have included the oncologists also in this practice. And it seems to be working. It seems to be working, at least for now, in Tamil Nadu, I'm hopefully it will, it will transfer to other states also. The last part is translating evidence into practice and future directions. What practice strategies can improve early recognition, timely referral? I think again we've gone through all these this one, but if you can just summarize, Dr. Rohan, I think we are repeating again and again. This is more to emphasize rather than repeat this one.
Yeah, I mean, as you said, I mean, awareness obviously is one thing, and for early referral, probably, as I said, we'll have to get, as you have shown that you've not only got hematologists but also medical oncologists on board, because a lot of hospitals do not have hematologists there. So that shows the kind of sightedness the government has shown, the interest the government has shown. So similarly, in this way, I mean, that shows that your primary health care is, how good is your primary health care is actually. It is a reflection of that fact. And hence I feel, there should be availability of automated counters almost in every PHC. If anything, gets flagged on the counters, there should be an early hematologist referral, and there shouldn't be any delay. I mean, it could be a false flag, doesn't matter, but there should be an early referral. And obviously, if it is possible, I think we should be looking at somewhere 5 years down the line, we should be having an hematologist in probably every district of the country. And with the kind of infrastructure that we need, infrastructure building we need, I think we should be looking at a situation where we reach numbers of that, so that we don't miss any cases, and more cases are actually picked up and treated appropriately.
Sure, thank you.
Can AI help in this?
Sorry, Dr. Meet?
Can AI help in this? Just
yes, definitely. I think AI will poke its nose into everything, and definitely in a good way, AI will come into helping in setting up registries and capturing patients. Especially because there'll be considerable overlap of these patients. I think AI can help in those. Okay, I think we are shooting past our time, so I'll just rapidly go through. Obviously, as I already mentioned, we lose a lot of patients to loss of follow-up, or even before the diagnostic this one, we lose a lot of patients. And most of our patients have to rely on immunosuppressive therapy. And in India, more than 50% of patients still rely on androgens, and about 40% on cyclosporin, only 10% to 11% for immunosuppressive therapies and transplants. And of course, the imported ADGAM, that's Pfizer-Horse ATG, has high cost and historically the gold standard. But we have domestic biosimilars, Thymogam, which is from Bharat Serum Vaccines, which seem to work quite well. And this is one of the studies which compared the innovator ATG with our Thymogam. The green bars is the Thymogam. That's a dual therapy with EATG and the cyclosporin. And Thymogam seems to be doing quite well compared to the innovator molecule. And of course, if you can combine it with erythropoietin, now that we have generics, it gives a much better response rate. And this is what I wanted to actually allude to. We have an existing Ayushman Bharat PMJ, which actually gives around 5 lakhs. But what I didn't know is that there is a national policy for rare diseases, which in fact gives a funding cap of around 50 lakhs per patient. Okay. But the problem is the bureaucratic rules frequently exclude the patients if they are enrolled onto the PMJ. Okay, so even if that patient gets aplastic anemia, those patients, because of bureaucratic problems, they don't come under the purview of the rare diseases, and they're not eligible for treatment like transplants and immunosuppressive therapies, which otherwise they would have been this one. So I think this strategic gap, there should be some way to this one. Again, affordable interventions like indigenous Thymogam validations and DKMS BMT expansion. Way forward is, empower the primary healthcare to identify secondary healthcare. That's the gatekeeper district hospitals. to do good bone marrow examinations and tertiary care centers where they can do immunosuppressive therapies and hematopoietic stem cell transplant. Goal shift should be to shift 65% of severe aplastic anemia presentation. They should be catching in patients with pancytopenia in tier 2 and tier 2 places itself. Again, whenever there is unexplained petechiae, unexplained fevers and pallor, if they have all these, this one, at least then they should be flagged for early referral. Okay, I'm going to flip through these slides. And I think where there is a way, where there is will, there is a way. I thank all the panelists for such enthusiastic participation in such a vague topic. We are more into treating patients rather than thinking about what we can do as aplastic anemia for the society. I think this was a fantastic discussion. Thank you all for such enthusiastic participation. I think we'll end the session by this. Is there any concluding remarks from anybody?
I can just say,
conclude.
Sir, thank you so much for this wonderful moderation. Real pleasure to see you in virtual mode, and we'll keep in touch. Thank you.
Thank you.
Thank you, sir.
Thank you,
Actually,
and good
it was
night,
very
everyone.
interesting to learn the Tamil Nadu way. I mean, this is something very interesting. I think a lot of other states should actually, learn what has been done and try to emulate the similar pattern. I mean, it's going to help, optimize healthcare in the long run. I think that's really interesting.
Thanks, Dr. Rohan.
Thank you, sir.